Usually when we talk about like getting a medical diagnosis, there's this expectation of just absolute precision.
Right, yeah, like engineering also.
Exactly. Like you break your arm, the x-ray shows a jagged white line, and the doctor just points at the screen and goes, well, there it is. That's the problem.
It's binary. I mean, it's broken or it's not broken. And we inherently crave that kind of visible, categorized comfort when it comes to our health.
But suddenly, when we look at our topic for today, that x-ray machine is just completely broken.
Oh, completely shattered.
Yeah. We are looking at a diagnostic landscape for female genital aesthetics and vaginal laxity that is just incredibly murky. We're diving into a topic that affects countless women, yet it remains, highly intimate, frequently whispered about, and just tangled in both deep societal taboo and immense medical complexity.
It really is.
So today our mission for this deep dive is to untangle the physical reality of vaginal laxity from the cultural obsession with genital aesthetics. We have a fascinating stack of medical reviews, aesthetic surgery data, and psychological studies.
Some really groundbreaking studies in there, too.
Yeah, and we are using all of this to answer a very specific, vital question. Can body image concerns actually amplify or even physically create the worries associated with vaginal laxity?
This topic, it perfectly illustrates the collision of biology, psychology, and culture. We are navigating the absolute definition of diagnostic muddy waters here.
Muddy is putting it lightly.
Right. The line separating a true medical necessity from just immense societal pressure is blurring more and more every single year. And determining what is, a biological flaw versus a culturally manufactured insecurity, well, that takes a lot of critical thinking.
And that cultural obsession, it wouldn't have such a stronghold if it weren't hijacking a very real shift in how we view the human body. To figure out why so many women are suddenly so anxious about laxity, we first have to look at the modern pursuit of the perfect vulva.
Yeah, that's where it all starts.
Because the data shows a massive, unprecedented rise in female genital cosmetic surgery, or FGCS. And what stands out immediately is the highly specific aesthetic ideal driving this boom.
We are seeing the widespread emergence of what researchers like McDougall, for instance, have termed the minimalist vulva.
The minimalist vulva.
Yeah, or sometimes called the clean slit. And this is a purely aesthetic ideal where the inner anatomy basically does not protrude beyond the margin of the outer anatomy.
So it's totally hidden.
Exactly. It's a look characterized by being small, smoothed, perfectly symmetrical, and essentially entirely self-contained.
Okay, let's unpack this, because it's like expecting everyday human faces to look exactly like an airbrushed, artificially generated Instagram filter, but applied to our most intimate hidden anatomy.
That is a perfect analogy.
Right, because if society constantly tells you that a digital filter is the default, the natural asymmetrical reality is inevitably going to feel like a deformity. But medical science actually spent decades trying to mathematically define this, didn't they? I read about doctors literally pulling out rulers.
They did. For years, there were serious clinical attempts to mathematically define the ideal genitalia.
Which just sounds absurd.
It does now, yeah. But researchers created these complex classification systems. Like you had the Hodgkinson and Haight definition or the Modakiffin-Banwell classifications.
Wait, they actually named these systems after themselves?
Oh, yeah. They were measuring the exact protrusion of tissue down to the millimeter, attempting to categorize morphological variations into neat, orderly little boxes.
Wow.
But the crucial insight from current clinical guidelines is that major gynecological and plastic surgical societies ultimately threw all those classification systems in the trash.
Because you can't standardize a fingerprint.
Precisely. Human anatomy is wildly, beautifully diverse. There is no single normal.
Right.
Yet, despite a solid medical consensus that anatomical diversity is the biological default, clinics are flooded with women requesting surgeries. And not for physical pain, but overwhelmingly because they feel, quote, enlarged or loose or asymmetrical.
Which means something outside the doctor's office is driving this insecurity. And we have to look at the collision of modern fashion and grooming habits, because they have completely transformed our relationship with our own bodies.
Oh, absolutely.
Like we're living in the era of athleisure.
Yeah.
The normalization of tight-fitting sportswear, ultra-snug yoga pants, and minimal underwear like G-strings.
Yeah.
It essentially forces an internal anatomy to have an external contour.
Yes.
And it has spawned a whole lexicon of popular media anxieties, like worrying about a camel toe or having an Audi.
You're taking an area of the body that historically was largely hidden even from the individual herself.
Yeah.
And you're putting it under a daily, highly critical spotlight.
Every time you go to the gym.
Right. Then you combine that fashion evolution with modern grooming habits. The sheer prevalence of waxing and lasering, it exposes significantly more genital skin than in previous decades.
That makes total sense.
When the hair is entirely removed, you reveal the natural, completely normal anatomical variations. The problem is, many women have simply never seen these variations in a non-airbrushed context before.
And the internet's role in this is fascinating, but also incredibly damaging. Because when you look at the images available online, particularly in pornography, they're heavily airbrushed.
Heavily.
But it's not always just for aesthetics, right? Sometimes it's due to bizarre content classification rules that deem explicit, realistic depictions of female genitalia inappropriate or too graphic. So they edit it out.
Which is wild.
It is. You end up with this incredibly narrow, often prepubescent aesthetic being presented to the world as the biological standard. It essentially pathologizes normal genital diversity.
And a sheer lack of basic anatomical education throughout life just leaves individuals incredibly vulnerable to this kind of media manipulation.
Because they just don't know any better.
Exactly. The clinical literature frequently notes a severe lack of textbook images that actually show the measurements and ranges of normal anatomical diversity. If your only reference point for your own body is a modified, airbrushed media image, the cognitive dissonance can be staggering.
I can imagine.
In severe cases, this manifests as body dysmorphic disorder, or BDD. That's where a person develops a pervasive, unrelenting belief that their entirely normal anatomy is hideous or defective.
Mhm.
And that severely degrades their quality of life.
But this cultural obsession wouldn't be quite so powerful if it weren't interacting with a very real biological process.
That's true.
Because the body does change. It's not entirely in the mind. So let's look at the actual biomechanics of laxity. What is happening on a cellular and muscular level when someone experiences vaginal laxity?
So biologically, vaginal laxity is a structural reduction in the elasticity and firmness of the vaginal walls and the underlying pelvic floor muscles.
Okay.
Imagine the pelvic floor as a complex, strong, fibrous hammock of muscle and connective tissue.
And that hammock holds up the pelvic organs.
Right, so when those tissues lose their underlying tone, the canal itself feels relaxed or loose.
And childbirth is obviously the culprit we hear about the most with this.
Oh, definitely.
The biomechanics of vaginal delivery require the canal to stretch extensively to accommodate a baby, which can overstretch or even tear that muscular hammock.
And the data shows the risk of structural change skyrockets with forceps deliveries, vacuum assistance, or delivering particularly large babies.
Plus perineal tearing.
Yes. But it's not just childbirth. Aging and hormonal shifts play a massive, unavoidable role.
Right, because everybody ages.
Everybody.
Yeah.
Menopause is a profound biological transition that completely alters the cellular landscape. We look specifically at something called the genitourinary syndrome of menopause, or GSM.
GSM.
Yeah. As estrogen levels naturally decline, the body loses a vital biological architect. Estrogen is the hormone responsible for keeping these specific tissues thick, elastic, and well lubricated.
So estrogen is essentially the fertilizer for the collagen scaffolding, and when it dries up, the whole structure loses its bounce.
That is a really great way to visualize it. Without sufficient estrogen, the vaginal walls undergo atrophy. They physically thin out.
Wow.
Production of collagen and elastin, the proteins that provide that structural scaffolding, drop significantly.
Right.
Even the local microbiome changes. There's a decrease in lactobacilli, which is the healthy flora that maintains the normal acidic environment.
And the physical symptoms from this structural shift, they are incredibly disruptive. The clinical data details reduced physical sensation during intimacy, difficulty achieving orgasm, and very practical daily annoyances like tampons slipping out of place. There's also the phenomenon of air trapping, sometimes called queefing, and stress urinary incontinence.
Which is very common.
Right, that's the leaking of urine when you cough, jump, or laugh. But we need to draw a hard clinical line here, right? Laxity is a loss of firmness, but it is not the same thing as pelvic organ prolapse, or POP.
That distinction is paramount.
Yeah.
Laxity is a change in the tissue's elasticity and the sensation of looseness. Pelvic organ prolapse is a structural failure.
A structural failure.
Yeah, it occurs when that muscular hammock weakens to the point that the pelvic organs themselves, like the bladder, the uterus, or the rectum, physically sink and bulge down into the vaginal canal.
So one is a change in sensation and tone, and the other is an actual anatomical shifting of organs.
Exactly.
But wait, I have to push back here for a second. The vagina is quite literally biologically designed to stretch and bounce back.
It is.
It evolved to handle childbirth. So at what specific point do these totally natural evolutionary changes cross the line from a normal biological phase into a clinical problem that actually requires medical intervention?
Well, what's fascinating here is that the clinical threshold isn't determined by a ruler. It's determined entirely by the patient's quality of life.
Oh, really?
Yeah, medical guidelines don't dictate a specific millimeter of stretching that equals a disease. It crosses the line into a clinical issue when it causes dispareunia.
Which is pain during intercourse, right?
Yeah. Exactly. Severe pain during sex. It becomes clinical when urinary incontinence disrupts someone's ability to live their daily life, or when the physical changes result in a devastating loss of intimacy and self-esteem. The diagnosis isn't just about the tissue. It's deeply tied to the subjective lived experience of the individual.
Which brings us to the most fascinating part of this research and really the core focus of our deep dive today. We have the cultural pressures demanding a perfect, airbrushed look.
Right.
And we have the structural realities of aging and childbirth fundamentally altering the tissue. So how do these two worlds collide? But more importantly, how do you even measure that? You can't just put body image or shame into a blood test.
No, you can't.
So how did researchers prove that psychological anxiety was actually causing physical dysfunction?
To measure the unmeasurable, we have to look at a pivotal study published in the journal Neurology and Urodynamics. This was by researcher Zelinsky and her team.
Okay.
They designed a study to map the exact relationship between structural, pelvic changes, genital body image, and actual sexual health.
And the methodology here is brilliant because they didn't just ask, like, do you feel bad? They used highly validated clinical tools to separately measure how an individual feels specifically about their genitals versus how they experience physical arousal and satisfaction.
Right. They used the Genital Self-Image Scale, the GSIS-20, and the Female Sexual Function Index, the FSFI. They divided a large group of sexually active women into categories. Those with documented pelvic organ prolapse, those who had undergone surgery to correct their prolapse, and those who had never had any prolapse at all.
And what did they find?
Well, the baseline finding was expected. Individuals with a structural prolapse had a significantly poor image of their own genitals compared to those without.
Which I think the data said the median score was 28 for those with prolapse compared to a median score of 36 for those without.
Exactly.
But the researchers did something really clever next. They knew that if you feel bad about your weight or your overall appearance, that's obviously going to affect your sex life. So they statistically adjusted for overall body esteem using the body esteem scale. They isolated the data to look only at genital body image. And even after factoring out general body insecurities, they found that a person's specific perception of their genitals directly mathematically correlated with their sexual health.
Yes.
Specifically, their baseline desire and overall physical satisfaction.
It's a profound finding. The specific, targeted negative perception of their anatomy was driving a measurable decline in their sexual function.
Wow.
The study broke it down even further using an appeal subscale. That measures whether an individual feels their anatomy is physically appealing to a sexual partner.
Okay, so how they think the other person sees them.
Exactly. And that single metric of feeling unappealing correlated with every single domain of sexual function.
Every single one.
Every one. Desire, physical arousal, natural lubrication, the ability to orgasm, all of it plummeted if the individual felt physically unacceptable to their partner.
Okay, here's where it gets really interesting. Let's break down the actual physiology of this, because it's like trying to get a high-performance sports car to accelerate while the emergency brake of psychological shame is pulled all the way up.
I like that.
Right, like the engine is fine, but the system won't let it move. How does feeling culturally inadequate or worrying about changes post-childbirth literally translate into the physical sensation of being too loose?
Well, it comes down to a powerful, overriding neurological feedback loop. The autonomic nervous system controls sexual arousal, and it's divided into two main branches.
Right, the sympathetic and parasympathetic.
Yes, the sympathetic is our fight-or-flight stress response, and the parasympathetic, which we often call rest and digest, is also deeply responsible for physical arousal.
And you can't be in both states at once.
You cannot. If an individual is anxious about how they look or deeply ashamed of physical changes, the brain interprets that distress as a threat.
A literal threat.
Yes. It activates the sympathetic nervous system, the fight-or-flight response. And when you are in a stress state, the body purposefully redirects blood flow away from non-essential functions, like digestion, and sexual arousal.
It pumps it toward the muscles and heart for survival,
Exactly.
meaning the pelvic floor is just starved of the blood flow it needs to respond.
You got it. During healthy parasympathetic arousal, blood rushes to the pelvic floor in a process called vasocongestion. The tissues swell and engorge with blood.
Okay.
And this natural swelling actually physically narrows the vaginal canal, creating the necessary friction for intimacy.
So if the emergency brake of anxiety is pulled, the brain blocks that blood flow. The tissue never swells. The canal literally remains physically wider.
Exactly.
The psychological worry about being loose literally starves the tissue of the blood it needs to engorge, thereby physically creating the sensation of reduced friction and looseness.
The brain and the pelvic floor are communicating in real time. The perception of the flaw essentially creates the functional reality of the flaw.
That is entirely mind-blowing. It means that in so many cases, it is not structural laxity reducing the physical pleasure. It is the distraction and the shame acting as a massive neurological roadblock.
Yes, exactly.
If you are stuck in your own head, terrified that you don't look like an airbrushed image, your body literally cannot deploy the blood flow required to respond, which then confirms your worst fear. You feel loose, you feel broken. But the hardware is fine. It's a software error caused by cultural conditioning.
Yet it completely reframes how we have to approach treatment. I mean, you cannot operate on a software error with a scalpel.
Which brings up a massive dilemma. If the mind is this incredibly powerful in creating the physical sensation of laxity, what happens when a patient walks into a clinic asking to be fixed? How is the medical world treating this, and are they even treating the right organ?
So the clinical data outlines a solutions matrix that generally falls into 3 tiers: conservative, non-surgical, and surgical.
Okay, let's start with conservative.
The absolute first line of defense is pelvic floor physical therapy, heavily focused on targeted Kegel exercises.
Which is essentially going to the gym to rebuild that foundational hammock of muscle.
Exactly. And the data strongly supports physical therapy, showing that targeted rehabilitation is incredibly effective, especially when practitioners use biofeedback devices to ensure the correct muscles are actually engaging.
Because it's hard to know if you're flexing the right thing down there.
Very hard. And for the structural changes caused by menopause, there is hormone replacement therapy, or HRT, and local estrogen therapies.
You're basically replacing the biological fertilizer to plump those tissues back up and restore the natural elasticity.
Exactly. Then we step into the rapidly expanding world of non-surgical interventions. These rely heavily on energy-based devices.
Right, like radio frequency and fractional CO2 laser therapies, things like NuV or Mona Lisa Touch.
Yes, the biomechanical goal here is to deliver highly controlled thermal energy deep into the vaginal tissues.
It's controlled damage, right, like aerating a lawn to make it grow back thicker.
That's the exact mechanism. The heat creates microscopic injuries in the tissue. This trauma triggers the body's natural wound healing cascade, stimulating fibroblasts to drastically ramp up the production of new collagen and elastin.
Which is called neocollagenesis.
Yes, it aims to firm up the structural integrity of the tissues using the body's own repair systems, with very minimal downtime compared to surgery.
But then we have the surgical interventions, and this is where the clinical guidelines start flashing red warning lights. We're talking about vaginoplasty, which involves surgically tightening the actual vaginal canal by pulling the muscles closer together.
Right.
And labiaplasty, which physically alters and trims the outer anatomy. The controversy in the sources here is intense, because one recent study showed that a massive 85% of individuals undergoing labiaplasty cited functional pain or discomfort as their primary motivation.
But major professional bodies, including the NHS and the American College of Obstetricians and Gynecologists, ACOG, have published strict policy statements expressing deep ethical concerns about these procedures.
Why are they so concerned if patients are saying they're in pain?
The pushback from surgical societies stems from a glaring lack of long-term randomized controlled trials, or RCTs, proving the safety and efficacy of these procedures for cosmetic reasons.
Oh, I see.
The concern is that medically non-essential surgeries are being aggressively marketed to exploit aesthetic insecurities rather than treating genuine pathology. And surgery carries severe irreversible risks.
Like what?
Over-tightening the vaginal canal can result in dense scar tissue. That scar tissue doesn't stretch, which can lead to entirely new, devastating sexual problems.
So you could make it worse.
Much worse, like severe dyspareunia, excruciating pain during intimacy, or worsening vaginismus, where the pelvic floor muscles involuntarily spasm and prevent penetration altogether. You can permanently damage the very function you were trying to enhance.
So, practically speaking, if someone walks into a doctor's office completely distressed, convinced they are too loose or aesthetically abnormal, how does an ethical practitioner know whether they need a scalpel, a laser, a physical therapist, or a psychologist?
Well, if we connect this to the bigger picture, this is where rigorous ethical clinical screening becomes the most important part of the process. Providers are strongly urged by guidelines to comprehensively screen patients before ever discussing surgical options.
Right.
A respondable clinician must determine if the physical symptoms are rooted in actual structural failure or if they're manifesting from relationship trauma, undiagnosed postpartum depression, or body dysmorphic disorder.
Because fixing the tissue doesn't automatically fix the mind?
No, it doesn't.
If your anxiety is blocking your body's physical arousal response, cutting away tissue isn't going to suddenly turn the arousal response back on.
If the root cause is a skewed, media-driven perception of what is normal, altering the anatomy will never cure the underlying anxiety. The insecurity will just shift to a new focal point.
It's heartbreaking.
It is. But this realization has made robust educational resources a primary treatment tool. Forward-thinking clinics are increasingly utilizing projects like the Great Wall of Vagina or the Labia Library.
I've heard of those. They're extensive, medically accurate photographic collections, right?
Yes, they are designed specifically to show patients the vast, completely normal, unairbrushed diversity of human anatomy.
It basically acts as an immediate clinical countermeasure to the homogenized prepubescent standard pushed by the internet.
Exactly.
And it turns out that simply showing someone proof that they are completely normal often cures the symptom of feeling abnormal much faster and much safer than surgery ever could.
Education is proving to be a highly effective medical intervention.
So what does this all mean for you listening right now? If we synthesize everything we've looked at today, vaginal laxity is an undeniable physical reality.
Yes, it is.
Childbirth, the biological shifts of aging, and the hormonal drop of menopause fundamentally alter the cellular structure and muscular strength of the pelvic floor. It is real, and it can deeply affect your physical comfort and quality of life. But this biological reality has been hijacked by a massive wave of cultural anxiety. Our perception of what is aesthetically acceptable deeply dictates how our nervous system allows us to experience our own bodies. If you internalize the belief that your body is flawed, your brain will literally pull the emergency brake, physically inhibiting your ability to experience pleasure and creating the very looseness you fear.
It serves as a profound reminder that we do not experience our physical bodies in a vacuum. Our biology is constantly responding to the lens of our culture. Which leaves us with a rather staggering question about where this is all heading.
Oh, where are we heading?
Well, if our physical sexual responses and our deepest body image insecurities are so easily manipulated by 2D airbrushed images on smartphones and in magazines today, how will our definitions of physical laxity or bodily flaws evolve as we plunge into an era of hyper-realistic, fully immersive virtual reality intimacy?
Oh, wow.
Will the biological, aging, asymmetrical reality of the human body ever be able to compete with a digitally generated, infinitely customizable ideal?
That is a wildly dystopian but entirely necessary thought to leave on. Are we inevitably going to chase an anatomical standard that only exists in lines of code? Remember the physiological feedback loop the next time you feel like your body isn't measuring up to an impossible standard. The diagnostic landscape might be incredibly murky, and the cultural x-ray machine for what constitutes normal is undeniably broken. But that just means you have the power and the biological imperative to define your own standard of health. Keep questioning the information and the images around you, and always look deeper.